All right, this is a little bit of a unique experience that we're doing right now. Most of you probably don't know, but 20 some years ago when I was at Regent College in Vancouver, I focused in my master's degree on bioethics, wrote a master's thesis on contraception in the Catholic Church. And I've long had an interest in bioethical issues at the beginning and at the end of life. And in particular, in the last few years within Canada, there's a conversation happening about euthanasia, something that we'll hear more about in a minute, called the medical assistance in dying legislation with respect to euthanasia, which means that this is really on the cutting edge of importance for many reasons, for bioethics, public policy, theology, all sorts of other issues as well. They all come to a head on this issue. So I am delighted to have a very esteemed panel of experts to discuss this issue. These are all individuals who have unique perspectives within a Canadian context on euthanasia, not just from the legislative and normative ethical lens, but also from the trenches of on-the-ground medical practice. So what we're going to begin by doing is I'll just go around the panel, beginning with Dr. Anna Work. Ask each one of my panelists to introduce themselves, take about 30 seconds or 40 seconds to share your name, your background, title, your expertise and experience and interest within this topic, and then we're just going to jump right into the conversation. So we'll begin with Dr. Work.
Hi there. Thanks for inviting me onto this panel discussion. So I'm a palliative care physician, I work with people who need palliative care support. My experience has been working on working groups prior to the legislation, the first legislation with medical assistance in dying nationally. And so I have an interest in this because I think really desire to kind of promote palliative care.
Okay, we can go to Gary then. Thank you, Anna, by the way.
Hi, yeah, happy to be here and thanks for the opportunity. So my name is Gary Frank. I'm a consultant nurse in palliative care, which means I work on a consult team. In this case, in a hospital for the last few years, quite a few years before that, similar sort of roles in the community and in hospice, managing hospice. So yeah, I've been a palliative care nurse for a long time, and I've also sort of through that gotten involved in clinical ethics committees quite a bit and other ethics, clinical ethics initiatives. And so this is a reason that I think is fairly evident as to why I'm interested in the issues involved in euthanasia and what's been called medical assistance in dying legislation.
Okay.
Yeah.
Excellent. Thank you. Great to have you aboard as well. Okay, Pat.
So yeah, I got to start in palliative care back in 1982, so that's a little while ago. And then that was at the General Hospital, worked in palliative care at the Misericordia Hospital, then went back to university to do a PhD to do research in palliative care, which didn't work out. But so wandered around in industry, but then I got lucky enough to work with the palliative care team at the U of A hospital, which was Dr. Work and Gary Frank and Twyla Downey. And in that time, I also got into clinical ethics, but I decided I wasn't done with school. So I went back to school to do a master's in theological studies. It was supposed to be an MDiv, but I had a little bit of a sojourn through stage 3 cancer. And so I've now actually, I'm working in an industry, but I actually am going to start my training to be a chaplain. So yes, this is something that I really welcome the opportunity to discuss. And it's something that I think we all have some experience with.
Thank you.
Hi, everyone. And I'm Twyla Downey. I've been a registered nurse for 27 years now, with the past 21 years being spent in palliative care medicine. And I've worked in the United States and Canada in a variety of settings, including hospice, palliative home care, and now in my current role as a consultant in a large acute care hospital. And I'm happy to be here with you all.
And we should say as well that Twyla is also one of my students at Taylor. And she has really led the way in getting me more aware of this legislation. And so thank you very much for that, Twyla, as well. So as you can see, there's a great group here, and I'm delighted to have all of you sharing your time on this very important topic. Now, euthanasia, the word, in terms of its etymology, comes from the Greek prefix eu is good and thanatos or death. So that's the etymology. But beyond that, just in terms of basic understanding about the concept of euthanasia and of physician-assisted suicide, I'm just going to throw those concepts out there, and whatever you'd like to share in terms of sort of background understanding of these concepts to set up our conversation. So feel free, whoever wants to jump in on that.
I guess I could comment. I did it's a while ago, but a fairly in-depth review of the use of the term for some presentations. And, you know, as you described it, from the Greek, the literal meaning was good death. And for a long time in English, it was used to simply mean that. It did not connotate, this is my understanding anyway, you know, actively hastening death or causing death. But that changed, especially in the mid-19th century. So anyways, it's taken on this connotation that in current English usage is clearly indicating hastening death. And I mean, there used to be this debate about passive versus active euthanasia. Most of us in palliative care don't use the term passive euthanasia anymore because it's very confusing and it can be easily confounded or mixed up with the right to refuse treatment on the part of the patient, which needs to be respected, of course, so long as there's an informed decision happening to the extent that's possible. So anyway, those are my initial thoughts.
Yeah, that's very helpful. Yeah, certainly that was a debate at one time between passive active, where passive is withholding, as I understand, is that correct? Withholding nutrition or hydration, or perhaps could it also be like applying something like morphine to an extent where through double effect that it might lead to death, or could you just unpack it a little bit more?
Well, I mean, the first responsibility for clinician, and I don't want to monopolize the discussion too much, but is to use intervention, you know, carefully and expertly and skillfully and judiciously. So assuming that's being done with something like morphine, I would agree your sort of suggestion that the principle of double effect, meaning an intervention might have two effects, one intended and the other not intended, but possibly foreseen, that might be a relevant ethical principle, although studies show that it often isn't actually necessary to invoke that principle because we're not hastening death, because we are using the drugs expertly in appropriate circumstances where patients are dying, and in fact they don't die just because we're giving them comfort measures. So personally, I wouldn't use the term passive euthanasia in that context.
Yeah.
Could I, oh, sorry.
Go ahead.
You go ahead. You go ahead.
I was just going to say, if I could just try to simplify things a little bit. So euthanasia really, so euthanasia and physician-assisted suicide are both terms with the intention to really cause death by administration of a lethal dose of drug. So that's the intention of both of these. Euthanasia would be when someone actually, I would say, to make it simple, to administer the medication. So for example, lethal injection. So for example, someone pushing the drug. Physician-assisted suicide is when the person actually takes the medication themselves. So it would be maybe taking some pills or whatever to expedite death. But I just want to be clear that the intention really is to give a lethal dose of drug to cause death. And those are, I guess, the two differences between the difference between the two terms.
Okay.
And those are quite critical because you do need, it's not pejorative to be precise about what we're actually talking about. It's so if somebody is asking for euthanasia, it would be voluntary euthanasia, but the way it's interpreted in the legislature or the legal statements is that that would be, as Anna pointed out, someone's administering that drug. You're not self-administering. So, and it's not just in, in the movies, you all think you can take one little thing, you crack your pill in your mouth and then you're gone and it's gone in seconds. But it's actually a fairly involved procedure with multiple medications. And there's also medications that are required to treat if things don't actually go the way it's not always just as textbook as you might think. So, because you're looking for one, if you think that there's one medication that's 100% infallible with causing the end to a human life without any kind of stress, duress, or suffering, that's not, we don't have a drug like that. And then the other one is physician-assisted suicide, and that's where the prescription's written and medications are provided for the patient to take on their own, unassisted. Now, the thing about that is that's even more problematic than the IV one. And that's actually several medications, a lot of them, in order to ensure that death occurs. But there can be problems with that, as with any oral medication. Someone might vomit, they can be agitated, things can happen, you can have incomplete absorption. So one thing that's happened with the latest, the change in the legislation, is to allow for, if somebody does that and then they're not completely dead, or they're left harmed by that, but still alive, one of the things they've added into is to provide that you can now take that unconscious person and then provide euthanasia. And so that's getting a little bit more blurred, right? So that's kind of starting to change things from where the original legislation, what it stated.
Okay, that's very helpful. That's a great segue, actually, to talk more about the legislation itself. So when did this legislation first get passed, and what was the sort of the quick overview of what it initially established, and what are the changes that are just coming online as of this year? That's for anybody.
Twyla, you did a good summary in an email. You want to give it a go?
Well, initially it came into play in June 17th of 2016. And at that time, it included patients that were terminally ill, where their death was reasonably foreseeable. And with that, it involved two witnesses, two signatures, saying that it was appropriate for the patient to receive MAID. The patient had to maintain their competency to make that decision. And then they would have a 10-day reflection period. And during the 10 days, they would have to still be able to be competent to make that decision. And then at the time proposed, at the date and time of the hour, the doctor and the MAID team would come in and give the lethal injection to terminate the patient's life.
Okay, so that's where we were in 2016. So it's been 5 years now. Now, as I understand, there were changes or emendations to the legislation as of this year?
Right, yeah, it just went through legislation passed in Parliament March 17th of this year, which eliminated the 10-day reflection period, or the having to have it in a case where the patient was terminal. It also reduced the witness signature to 1 instead of 2. These were safeguards that I feel were very important that they've now lessened. And then they've also opened it up to patients with disabilities, patients with chronic illness. And when I say chronic illness, that could include diabetes, asthma, it's very wide open. Also for people with mental health alone. And now the mental health, they've put together a panel, or they will be over the next 2 years, to discuss the qualifications for MAID in someone with mental health issues alone. But we're talking about a physically healthy patient with mental health issues only qualifying for MAID.
All right, I want to eventually get to some of the real concerns, and Twyla, you just touched on some of them. But first, I want to explore a little bit what draws people to euthanasia. Now, one theme that came up when we went through the sort of panel introductions is, people who are familiar with palliative care. So one of the questions I guess I have is, how good are we today at providing palliative care across the range? Are there still cases where people really have a reasonable fear of insurmountable suffering that they might look forward to in the process of dying or in a diminished quality of life? Or is palliative care such that there is a reasonable control over that could assure people that they don't really have to consider this as an option?
Sorry, could I just clarify something, Randall? Just for our listeners, in case we weren't clear. So medical assistance in dying is the term that is used in the legislation to encompass both euthanasia and in Canada, physician, not to euthanasia, but that has both of them in it. So physician-assisted suicide and euthanasia. And so that term now encompasses both of them. And so that's, I guess, what we're talking about right now. And I think it would be important just to clarify what palliative care is, because I think a lot of people don't understand what palliative care is. And so just the distinction, I know you had talked earlier about the question about withholding and withdrawing treatments that may be life prolonging or life sustaining, and that is not considered euthanasia or assisted suicide. So that would be part of allowing natural death to occur. So palliative care really is an approach to care, and it improves the quality of life of patients and their families who have maybe life-threatening illnesses. And that we do that through relief of suffering by treating pain and other problems such as physical pain or physical symptoms, psychosocial and spiritual issues. And that's the World Health Organization definition that most people will follow. It really affirms life, and it regards dying as a normal process. So it really doesn't intend to hasten or postpone death. So just to make sure that we're all on the same page, because I think it's unclear. Some people think palliative care is actually euthanasia or physician-assisted suicide. And I just want to make that distinction that they are considered two separate things.
We get calls every day in our office. Could you please organize euthanasia? And we say, we're not the MAID team. So yeah, thanks.
Yeah, that's very helpful. Let me put it then like this. Is the relationship between palliative care and MAID, that umbrella term for those two different, euthanasia and physician-assisted suicide, is the relationship between those two a zero-sum game? So what I mean by that is a zero-sum game is where there's a limited amount of resources. So the more you give to one individual, the less another person gets. It's like there's 6 pieces of pie. If one person gets 4, then there's less for everybody else. A non-zero-sum game would be where 2 things can be complementary. So there's not a limited share of resources. And so by asking the question I'm asking, if there is the availability is made, the availability is given for MAID, does that undermine to some degree palliative care or the impetus that people have to seek a remediation of suffering through palliative care rather than through euthanasia? Does that make sense?
Yeah, I mean, it could. So a few things. In answer to your question just a minute ago, Randall, like palliative care has progressed, and some of us have seen that, and it's improved, and it can be very effective. But we would be just totally unrealistic to suggest that people don't suffer and that there aren't situations where it's very difficult. And I mean, when those situations arise, those of us who don't advocate euthanasia will offer deep sedation, which is usually when there's limited time of life expected in any case. But I just to sort of get to the fundamental point that comes to mind in response to that question, like one of the problems in this whole debate is our kind of naive and superficial consideration of suffering and ill-advised sort of an unreflective approach to suffering as something that medicine could somehow entirely eliminate, or it's just, that's not the human condition. So anyway, there's some thoughts on it.
Anybody else?
Yeah, I would just like, I mean, when I got into palliative care, I mean, one of the things we often like to quote was that we were there to cure sometimes, to relieve often, and to comfort always. And that was actually our mission statement. And I think you bring up a really good point. You know, so I'm trained as a pharmacist. I have a PhD as a clinical pharmacologist. I develop new drugs. But I have to tell you this, drugs aren't the only thing that leads somebody to comfort them. And as a matter of fact, I think that drugs can be a very crude tool sometimes. I think it's necessary. Sometimes, you know, intractable pain, you know, we're actually fairly good at treating most pain syndromes and things like that. But if you're saying that we're going to use up all of our opioid, or we're going to use all this, and then we have no choice but to do something else, I don't know that it's that dire. Because the other thing, so I'm a big fan of Viktor Frankl, Man's Search for Meaning. And one of the things, interventions that we'd like to be able to do in palliative care is help people find meaning still within that suffering. And of course, within, you know, different religious traditions, we always say, well, there can be some meaning to suffering. Now, I don't believe people should just suffer needlessly. But I was Barry Bullets works in psychosocial support for cancer in Calgary, and he did his PhD with Viktor Frankl, and we've sort of hit it off. And he looks at interventions in palliative care. Yes, you want symptom control, and that may involve medications, that may involve physiotherapy, it may involve surgeries, it may involve all kinds of medical interventions. But it also, especially when people feel that there's no meaning left in their life, I do think that's when people look for that, you know, euthanasia. And so,
go ahead, Pat.
He wants to, yeah. So what I think we also try to do is help people still find meaning in the life and even in the suffering that they have in the time that they have left. So interventions that help you find meaning is one thing that can really help. And I have seen, and I'm not saying everyone does this, but I have seen people transcend their illness in ways that I can't even fathom, that you would think, well, they have terrible bone metastases, that should be terrible pain, and yet they don't seem that bothered by their illness. So somehow they've managed to find that meaning. But I'm not saying that's an easy thing to do, and there's no pill for it. So go ahead, Gary.
Well, no, it's definitely a values question in terms of why people are choosing this. So study after study has shown, and others can correct me if you've seen different studies, but repeatedly that people who choose euthanasia or physician-assisted suicide as an option and proceed with it are not doing so because they have a higher symptom burden or because they're suffering more physically in any case. They're doing so because their emphasis on autonomy as value and control is primary. And that's why they're proceeding with it. I don't know. I've seen that demonstrated a number of times. I don't know if anyone else has comments on it.
We've seen what has been termed a duty to die in many patients. And when I explore their feelings and their fears of dying. And I heard from one gentleman, he wanted his wife to be able to move on and not to see him slowly pass away. Another gentleman told me he can no longer work and didn't want to be a drain on society. And that's why he requested euthanasia. And these are patients that are up and they're walking around. You know, the media kind of portrays people in horrible suffering that are in bed and being prolonged in the suffering. And that's not always the case, you know, and we're seeing that again and again. And just to go back to palliative care medicine, you know, to use medications to alleviate suffering, such as pain and nausea, other symptoms. Physical pain, what I found with a very dedicated, experienced palliative care team is that physical pain and symptoms are easier to treat than emotional and spiritual pain. And unfortunately, a lot of times in palliative care, we don't have the time and resources to address the spiritual and emotional pain. But that comes into play as well.
Yeah, very well stated. One thing that's kind of in terms of this idea of narrating, providing a framework of meaning, as with Frankl and so on, for one's suffering, is I think often the way people frame the conversation about euthanasia is with the phrase death with dignity. So I'd like to hear from you how that strikes you. What is being assumed, how one defines dignity, and how do you think about the concept of dignity from your own background, journeying with people through the process of dying?
Well, for me, you know, our goal in palliative care is that we are working with people that, you know, there's no more treatment options usually. And, you know, the goal is to help them to die well, to have a good death. And that is the goal. And that is in adjusting medications for comfort that maintains their level of cognition, that they can visit with family and enjoy that very precious time that they have left to the best of their ability. So that's what I wanted to add into that.
So if you think about it, about what's implied when the term death with dignity is equated with euthanasia or physician-assisted suicide, as if that's the only way to have a dignified death. What's implied is that it is impossible to have dignity and have any degree of dependency on others. And this, to me, is extremely problematic. It's also implied often when the term quality of life is used, and autonomy for sure. You know, something that struck me recently, I was listening to the news, nothing to do, I thought, with my work. And they were talking about this awful case in the States where George Floyd was killed. And they were interviewing the police chief of the Minnesota police force. And he kept emphasizing how the principle of sanctity of life is important. And it just struck me like that used to be the principle of discussion very often in health ethics, but I have not heard that term used in a hospital in a number of years now, which is very interesting. I don't want to overinterpret it, but we always talk about quality of life. Sometimes I think in a presumptive way, as if we could somehow judge somebody else's, which we really can't, quality of life. But, well, and you know, we do need to be careful, like biological life should not be considered an absolute value beyond all else. That's not a Christian perspective, for example, and it's not really a rational one to, you know, this kind of vitalistic obsession. But to say that life should not be regarded as sacred or have sanctity unless somehow sort of fictionally autonomous is really problematic. Sorry, I'll stop. But that really struck me the other day when I heard that.
I just wanted to kind of pick up that thread a little bit because, you know, one of the things we talk about sanctity of life and quality of life, but the one thing is I've seen so many patients, you know, and again, yes, you have to let go and you have to recognize that you may not be able to do some of the things you do. And we used to do this exercise to show that as you have cancer and it progresses or whatever progressive illness you might have, you may lose the ability to do some things for yourself. Now, but it's also really nice to be a family member to say, I'd really like to help you with that. And you've done all these things for us. Is there something we can do for you now? So there are ways to help with that. I mean, I have seen some patients asking for euthanasia. It was entirely a control. It was, and I, not only that, I wanted the day and the time, and I was a veteran and I wanted to die on this day. And it was entirely about control. But I do worry. I mean, let's face it. I mean, you know, as far as this realm goes, this, you know, death is final for this existence. And you may have lost an opportunity. And I've seen that so many times in palliative care too, that someone's, yes, they're suffering, they're in anguish, maybe not physically, but emotionally, spiritually, and a long lost brother shows up, or a family member makes it that was trying to get there. They had been estranged for years and they had that opportunity. Now it doesn't happen all the time. And you can't, I remember one of my social workers used to say, I wish I had a magic wand. You know, I'd like to make this happen for everybody. But if you say, well, tomorrow's it and I'm done, and then something else happens, that opportunity was lost. And one of the things I always really felt working as a pharmacist in palliative care was you had windows of opportunity to help people do amazing things. And it might be just the chance to finally say, I'm sorry to someone you always wanted to say you're sorry to, or I love you to someone that you really should have for years and years and years. But once you've administered all those life-ending medications, that opportunity is lost. Now, I'm not saying, again, it's like, how can I help somebody maybe see that they might still have that opportunity? And that's not an easy thing to do.
Yeah. My own father died 2 years ago from Alzheimer's. And my brother, they were living in the same city, and my brother had been a high school teacher for 20 some years. Well, he had just, at the time that my dad was declining, he left that position, didn't know what else he wanted to do with his life. He spent a lot of time with my dad and journeying with him through Alzheimer's, through his loss of cognitive function, his loss of control over his bodily processes. And as a result, my brother ended up becoming a healthcare aide. He says, you know what, this is what I want to do in the world now, is journey with people on this near the end of life. And so that's what he does now, and he loves it. And yeah, like if my dad had just said when he was diagnosed in December of 2017, I'm done, then certainly that would never have happened. So I certainly resonate with that. Now, I want to cycle back to the changes. And because all of you know from your own practical experience, you have so much just practical knowledge about how euthanasia impacts people. What is most concerning to you about the changes that have been implemented as of March? And why?
I'm just going to dive in with the one that concerns me. Again, I think one of the safeguards was because what the new legislation says is the patient applies, and then you only need one other person to agree. It used to be 2 physicians. It used to be 2. And for instance, if you go and you look at what's happened in the Netherlands, they still have 2, even though they've gone down to 12 to 16-year-olds can't apply. They need to have their parents' permission, but from 16 to 17, maybe not need their parents' permission, and then 18-year-olds, you can do it. And they also have reviews. So I think they've removed some of the checks and balances. That worries me a lot. And it also worries me within a context. I mean, the pandemic has revealed a lot about, especially some of our politicians. We'll hear things like, oh, it's maybe time for the older generation to, just take a hit, take one for the Gipper. I worked with one minister of health that referred to frail elderly people who are in acute care as bed blockers. And it's like, it was hardly that elderly person with a disease's fault that they were in an acute care bed when our government, we hadn't put anything into long-term care for decades. So that's one thing that I think, well, that's taking something out. And the other thing is, a lot of this stuff is enacted by politicians and legal, and then it's all placed on physicians. It's all placed on nurses and nurse practitioners. It's like, now you guys will go do this. And it's like, it may seem very straightforward and easy if you're doing the legal arguments, but on the ground, help with the patient, I don't think that they realize how that affects us as practitioners, but also even that this can now be part of a family dynamic. It's like, well, because now I could feel that I'm a burden, maybe it's time, maybe I should stop doing, my family must be tired of this, and we've heard that in palliative care for many years. People would say, I wish this was over because I think it's a terrible burden on my wife and things like that. So I'll stop there, but that's one thing that does concern me quite a lot.
I think one thing that concerns me really, a lot of this concerns me. There's a lot of problematic and challenging things with this new legislation, but I would say that, this is a game changer because now you don't have to have a reasonably foreseeable death, whatever that meant before, which we don't really know the definition of that. But now you don't have to have a natural death that may be reasonably foreseeable. So that opens it up to other people who now may meet the new eligibility criteria, which may include people who have vulnerabilities, people who don't have homes, or they are in situations that are difficult, people who have disabilities. And so you don't have to have, you could have a diagnosis that is not life-threatening or life-limiting in itself. And so I think that is, it opens up a can of worms in that now we're being more permissible, and people may be coerced into doing something, and they may, now have that opportunity or that ability to shorten their life, whereas before they couldn't. So that's, and I worry for the people with the vulnerable populations and where that may lead. Yeah, it's quite problematic, I would say.
One community I really worry about is our First Nations community. There's already concerns about inequality, about racism. There's a very, very high suicide rate among some communities. And the elders are working really hard in suicide prevention, and this seems to undermine all that work. And so the mental health piece really is concerning to me. I see this as being very harmful. We know with mental health that there are times when the illness is well controlled and times when it is not. And I really fear for the patients during the times when it is not. The other thing with the 10-day reflection period, it was a good safeguard, because often in acute care hospital, if somebody brought up MAID, sometimes in desperation because their symptoms were so poorly managed, and our team comes in, adjusts medication, the very next day, a day later, they're no longer requesting MAID. And 3 days later, I had one gentleman tell me, I'm comfortable, I'm happy, I want to go home and spend time with my family. Imagine if they had provided euthanasia on day one. Giving palliative care time to get in and to manage patients' pain, their symptoms, give the family support. In that scenario, patients may choose life. And that's what we hope for. Part of our job in medicine is to help foster hope. And sometimes that hope changes, but there's always ways to look for that hope. And I really worry about this bill for a number of reasons.
Yeah, I share those concerns. And actually, just following up on what Twyla said, there's a number of cases and well-written biographies of folks who've had trauma like quadriplegia, paraplegia, who were wanting to die at the time and later say, boy, I'm glad that I wasn't taken seriously. Not that wasn't acted upon, at least, not that they weren't taken seriously in terms of their suffering, because later on they've adjusted to a very fruitful and creative life. I have this concern about a kind of gradual eroding of a medical culture, a sort of nihilism that's kind of synergistically works together with the risks that vulnerable patients are facing, in that like, for example, I teach medical students sometimes, and I've noticed in the last couple of years there's this assumption to begin with that actually palliative care is medical nihilism. It's just like you don't do anything because there's nothing to do, and so you just kind of talk nice. That's it. So the moment you get into that mindset, the whole rigor of your profession starts to be potentially eroded, unless you're in some really high profile, we're going to cure everything type of mode or environment, which can have its own problems for sure. So I try to get through this point that no, it's not medical nihilism. In fact, the main thing that prevents that attitude is actually getting back to the real basics of even pre-medical, technical, advanced type of interventions, and that's the therapeutic relationship. Like if we forget about that, if referring to just sort of okay, we can give you this option and that's the end of it, and then there's no more relationship, obviously, then we've really got a problem in the professions as well, and the culture. Anyway, thanks.
Gary, I just really like to echo that. Even when my experience as a patient, I could always tell when my surgeon came in the room, even though if I couldn't see him, because I'd see my wife's face light up, because you just feel better when he came into the room, you know. And the same thing. I got very sick post-op, went into pulmonary edema, and they wanted to drag me off to ICU, and I didn't want to go there because I'd worked in ICU for a long time. And they put the same nurse with me every single night. And she says, "You never sleep." And I said, no, I sleep. She says, "No, I'm in here every hour on the hour and you never sleep." And just, I felt better because of the people that were caring for me. And so I just want to say that I don't know that people who haven't been a patient realize how important that is, the relationship that you have with your caregivers. Because it just, I mean, I don't think you can bottle that and put that in a pill. That's all I'm saying.
Yeah, very well stated. As we kind of draw this conversation to a close, I mean, I think we've clearly just scratched the surface here. What I'd like to ask from each one of you is just any final thoughts that you have, anything that we didn't touch on that you'd like to talk about, address, share, and also along the way, if any of you have any suggestions for what a person can do now. So there's no doubt there's a lot of Canadians who haven't been aware of these changes. And I mean, I just didn't see much being reported at all. I think probably to some degree, COVID has just stolen a lot of the headlines. So people are just not aware. So if people want to get more informed, if they want to maybe participate and have their own voice heard, if they have concerns, etc., how can they do that? How would you recommend they go about that? So I'm just going to throw it open. If you could all just kind of share whatever last thoughts you have and any recommendations you have for people thinking further about this, that'd be great.
I just want to encourage everyone who's concerned to write their member of parliament and let them know. Let Trudeau know, let the Minister of Justice know, the senators in our province, and just get your opinion out there. I mean, Canada is a democracy, and this is happening in our home country. It's not happening over in Europe anymore. It's happening here. And just to, just to raise awareness and to get people involved that, this is happening. And for me, I want to protect the vulnerable. And I see many, people with disabilities very vulnerable, because I can see, reviewing what's happened in other countries, is that there could be a societal shift in the way society views people with disabilities, with chronic illness. And that's very frightening. So, yeah.
Yeah, and I just want to emphasize that it's really important for non-professionals who are concerned about this to speak up, because us professionals are kind of seen like a vested interest, a lobby group, and after a while, I'm not so sure we're listened to because we're in a minority, first of all. But if you found what we've been saying that it's making sense to you, then your voice is really helpful.
I would say, if it's possible, there's a lot of people never, visit, anytime you have a friend, loved one, visit them in the hospital, because it makes such a big difference. And if you can, volunteer. I mean, so if you can go in and spend some time with people, when they feel alone, feel hopeless. And when you're hopeless, that's when, well, what do I have to live for? And honestly, I've gone in to assess patients to say, should we put them on this medication that will make them calmer? And it's like, could we have someone sit with them for a while? And you don't need a lot of specialized training for that, just to reach out to somebody. And one of the things I think I see in our society is it's too removed. Even with COVID, it's like, well, I'm not aware of somebody that's sick. Now, it's hard to volunteer and go into a hospital right now, but if you can, one thing you'll get back. You won't believe what you'll get back, but that can really change people's lives.
Yeah, and I guess I just wanted to kind of summarize what everyone has said. And I think the key thing that I think we often forget is how to be a community and how to reach out to one another. I think we've talked a lot today about autonomy, about independence, about control, about dignity, and, you know, doing things on our own. But, you know, we have people, there are people out there, and I think we need to come together, to journey together in this. It's difficult. And I know, you know, we really want to help people to live until they die. And so how do we do that? How do we come alongside people and accompany them on the journey of life, really, so that people don't want to end their lives early because of loneliness or isolation. But I think it's our responsibility, and I think Canada is built on that. Our society is one of a caring society, really, I would say. And I think somehow along the way, and we've sort of lost that that vision of being a community and looking out for one another, you know, being a neighbor. And I think that's important. So I think, especially during these times, is to try to reach out, as everyone on the panel has mentioned already, and reach out to whoever may, I mean, you never know, right? What they may be feeling. And so I think that's our responsibility to look out for one another.
Well, I want to thank you all. That was just right there, so beautifully stated from each one of you, providing a different angle, but all mutually complementary, from dealing with a sort of more abstract legislative aspect to the practical of just sitting by the bedside and everything in between. It really challenges me, and I think it's going to challenge a lot of other people. What kind of society do we want to be, and what are we as individuals doing to help bring about the society that is consistent with our values? So thank you so much. I really appreciate the time that you've shared and for informing me on this important topic, and everybody else as well. So thank you.